Broadcasting from the Cass Corridor in Detroit, it's the Metro on WDET. I'm Tia Graham.
And I'm Robin Vincent. Today on the program, the killing of the United Healthcare CEO has sparked a lot of conversations.
Conversations about political violence and also about health insurance in the U.S. and the many frustrations people have with their coverage.
Today, we'll take the temperature of health insurance in Metro Detroit and beyond, and we'll look at how things like medical debt affect a person's quality of life.
And the CEO of Stellantis is out. We'll talk about what's next for the auto company, this and more, but first, Detroit Youth Choir is ready to strut its stuff and branch out a little bit this holiday season. If you're not familiar with the young performers, they have lit up stages from America's Got Talent to the stage of Carnegie Hall. This Friday, Detroit Youth Choir will perform not one, but two concerts for audiences. The first half of the concert will include soulful renditions of classic Christmas songs, and the second half of the concert will begin a transition for the choir, as the choir begins to sing more songs that kids enjoy. And they've been busy this fall. The Detroit Youth Choir released the Equations album. The 10 songs represent 2 years of hard work. Joining the Metro now is the president and artistic director of Detroit Youth Choir, Anthony White. Anthony, welcome back to the Metro.
Thanks for having me. Hello, good morning.
Hello. So the last time we spoke and the last time we talked about Detroit Youth Choir on the Metro was back in February, maybe March.
Yeah.
And we were talking about the Disney Plus a docuseries. And since then, you guys have been just busy. You've been in Africa. I saw the performances you did in Africa.
Yes.
Talk a little bit about what you all have been up to.
Well, of course, DYC been busy. I'm just making my rounds and doing a lot of, gathering of interest for this show coming up. We've been working on this holiday / album release concert for the last half a year. And that's pretty much what we've been doing. We've been recording and producing this great album called Equations. It's kind of like a collection of thoughts and feelings that these young people have. Of course, collectively written with our young people. Plus, Buddy, he's one of our producers, and D Slate. He's one of the premier producers in the city. They both collabed and with me, and we created Equations. And then I was like, well, how can we bring this to life? And the only thing I can think of is collab it with our annual Christmas concert.
And thinking about the Christmas concert, and just talking about it being broken up in two parts, let's talk about the first part, which is happening in Dearborn. I wanted to know why you decided to choose the Performing Center, because I actually graduated in my high school's graduations there. So, it's a beautiful space.
Yes.
And it's a beautiful space. So talk about that space and why you all decided to have the concert there.
Yeah, big shout out to the Dearborn Ford Performing Arts Center and Tiffany and Eric there. They welcomed us in again because we did it last year there. And, it's just a beautiful space. It has the room. It has the big stage. So that's what we kind of wanted for this show. The sound is going to be perfect. The lighting is going to be perfect. And the young people is going to just kill the stage because that's what we do. We just wanted to have it here. It's plenty other venues, but this one, we rock that stage.
And talk about the songs, the holiday soulful renditions that you all prepared for the audiences.
Ooh. Yeah, so the first half of the concert is going to be our traditional, soulful, kind of uplifting Christmas songs. You have the Limelight Choir, which is our babies.
Yeah.
They're going to do their set, which they have the Mariah Carey song and all that stuff.
So how old are the Limelights? How old are the babies?
You talking 8 to 12, 8 to 13-ish. They're babies, and they're our training choir. And then you have the Center Stage Choir coming at you with This Christmas and chestnuts roasting on an open fire. Yeah. And then you have Primetime coming with the bomb. Just boom. They coming in with Carol the Bells and a couple of gospel Christmas songs. Oh, Come All Ye Faithful, arranged by the Sunday service choir. Yeah, it's gonna be cold, out cold.
And so, we have the holiday portion where people are going to come and, of course, enjoy their holiday festivities.
Yes.
You're going to have a little market beforehand as well so people can kind of convene together.
Yeah, we have a marketplace.
Yeah, so you're going to have so many different things that folks can do holiday themed, but then you're also breaking free. You're breaking out.
Yep.
And the second half of the concert is the Equations album release. And here is one track we want to get to, and then we're going to get into that album.
All right.
So when I was listening to the album and I was going through it, at first I didn't know what to expect. I didn't have any expectations, but I listened to it and I thought, oh, this is going to be like Kids Bop. You know what I mean? It's not Kids Bop. It's not Kids Bop at all. It's very well produced, well put together. So talk a little bit about, number one, the second part of this concert that we're going to listen to these songs that were put together and produced over 2 years, but the process of it all.
Wow. I mean, just to get these young people in the same room, into a recording studio was a task. It was very difficult because, we're performing, we're traveling, and we have our own shows and rehearsals. So it was like, all right, today, guys, we're not doing our stuff. We're going to do the album. So they would have to come in ready to go. And you had some young people that was like, well, I can't make it because of this and that. But the end result was a beautiful album, and I just give it up to our producers. I mean, D. Slate and Buddy, I mean, these two guys are extraordinary. And just for them to write something like this, I mean, on my mind, we have another track called Vogue.
We actually have Vogue queued up. So he's queued up Vogue, so we're going to queue up Vogue.
All right.
Slate put it on, boy.
This is one of the songs that when I heard it, I said, oh, I'm dancing to this for a while. I mean, I'm going to be gigging to this for a while.
Yes.
So when we think about this album, the way it's produced, of course, this is music that kids will vibe to, but also adults were all vibing in here as well.
Yeah.
And as well, I heard you can hear the producer tag.
Yes.
This is a producer who's worked with people like Ty Dolla $ign, and he's worked with some of the biggest names in hip hop right now when I hear that producer tag. So talk about them having the opportunity to work with a professional like the professionals they're working with.
Let me tell you, I first met D. Slate on the set of a music video from Pastor Mike Jr. We did the video for Amazing. My God is amazing. So we did the video for that, and he showed up, and I was like, you're a producer? He was like, yeah. He was a young guy, right? So I'm like, well, we looking for somebody, and we need an album. Next thing I know, boom, Poppin' came. Then, Mama, we made it. And then he was like, okay, why don't we just do a whole project? Wow. And this guy took DYC in and made them his family. And that's what I like about Slate. He has his prices and everything. I mean, what producer don't, right? But they're fair, and everything about him is real smooth and cool. And then Buddy is the songwriter, and he was like, Mr. White, give me a vision. I gave him the vision, how we wanted the album. And it was like, well, we need to talk to the culture of Detroit, the culture of the world, and what's going on with these young people. Because, we have a song called Lonely Road, right?
Yeah,
and it talks about the, at times it's a lonely road. It talks about the depression piece of being young and being my age. I mean, I haven't been depressed in a long time, but it was a time when I was younger and I got into a depression mode. And that song, kind of, I'm getting goosebumps talking about it. And I mean, it touches a lot of people. So that's kind of what this album is about, equations, for sure.
I just, love that we have an opportunity to hear kids process their emotions in this way and actually have a space where they can talk about it and other kids listen and say, you know what, I'm not alone in this situation. And that producer is Dustin Slater.
Yes.
And did an amazing job with the album. But
Beautiful.
While we're talking about the contemporary music and different things like that, I'm thinking about what's next for DYC, because you have the concert that's coming up this Friday that you all have been preparing for, a 2-part concert. But then you also have the album release that's happening. But you have so many other things that you want to accomplish in 2025. So what else can we expect?
Well, this is what I'm putting this out there right now. We really, of course, we're going to have auditions, right? January 4th. Auditions is going to be at the Mary Grove Conservancy from 12 to 5. So if anybody out there have any young people that's interested in singing, performing, please bring them to the Detroit Youth Choir January 4th, 12 to 5. At the Mary Grove Conservancy. And I want to just put something else out there about us having our own home. Like we're at the Conservancy, right? But we want our own building. We want our own headquarters. And that's what I really want to go for in 2025. I also wanted to say something about being in the movie, but I'd rather put that on pause to get our own home. I really want our own Avengers type building with the big DYC logo on the top, like the Avengers, Marvel's Avengers or whatever. But that will be so sweet for our young people to have a place where they can go and do homework, play video games, congregate, like a kitchen, have a kitchen, a lounge. That's what I really want for these young people.
Yeah, a space that they can call home away from home.
For sure.
And, before I let you go, we're going to have the last song play us out here, Mama, We Made It, which I absolutely enjoy. Listen to the beginning there. You had Queen Latifah narrating the beginning of that song. I love that so much. But just the last thing as well, just talking about everything that you all have been able to accomplish. We're winding down. We're going into another year. Just what would you say to your kids or the parents or just your family, your DYC family, especially as you're going into 2025, about what they've been able to accomplish in 2024?
Well, I just want to let our parents know and our fans and everybody know that DYC is a process. When you put your young person in DYC, they won't be a star overnight. It takes years. It takes a lot of rehearsing and a lot of practice for them to be who they are. For you to hear what this album is and how they sound, it's a process. And I just want to give it up to our staff for making this thing happen. It's just not me. It's another team behind me. And, just stick with it, y'all. Stick with it. Stick in it. It gets hard, but just stick through it, and everything will be okay.
And here is Mama, We Made It by Detroit Youth Choir. Just want to say thank you to Anthony White, President and Artistic Director of the Detroit Youth Choir.
Hey.
This fall, the Detroit Youth Choir released their album Equations. They performed this Friday in Dearborn. Anthony, remind us the details.
So we have our concert this Friday, 7 p.m. at the Ford Center for the Arts in Dearborn, Michigan, right on Michigan Avenue. Be there. We have a marketplace. Starts at 5 p.m. And so come out and shop. All right. We love you. DYC loves everybody. And Mama, we made it.
From the WDET newsroom. A commercial poultry farm in southwest Michigan has become infected with bird flu. It's unclear how many birds were infected and if they were chicken, turkey, or another kind of commercial flock in Ottawa County. U.S. Department of Agriculture policy states that any poultry facility that's become infected with H5N1 must be called to reduce the risk of spreading disease further. State officials are urging farmers and their workers to beef up biosecurity measures. That means disinfecting equipment and enclosing coops. There have been 2 confirmed human cases of bird flu in Michigan so far this year. Coming up at 11, Americans are frustrated with the healthcare system. The phone lines are open. Have you ever avoided seeing a doctor or not gotten a prescription filled because of the cost? Have you ever struggled with medical debt? Call and tell us about your experience, 313-577-1019.
Up next, the CEO of Stellantis abruptly resigned on December 1st. We'll learn why and what that means for the automaker. Stay right there. Welcome back to the Metro on 1019 WDET FM. I'm Tia Graham.
And I'm Robin Vincent. Stellantis is going through some changes, and fast. The automaker that includes 14 brands, Fiat, Chrysler, Jeep, and Dodge, among others, is going into 2025 without the only CEO it's ever had.
Carlos Tavares, who has led the company since its formation in 2021, abruptly resigned on December 1st. Tavares' resignation comes amid disagreements he had with the board.
Here to explain what went wrong and what's next for the automaker is Jamie Butters, executive editor at Automotive News and host of the Daily Drive podcast. Jamie, thanks for joining us today on the Metro.
Glad to do it. Glad to be here.
So Carlos Tavares is the only CEO Stellantis has known. Give me 30 seconds real quick, though, of how Stellantis came to be before we get into that.
Sure. You know, the former Chrysler Corporation, probably half your listeners don't even remember a time when there was a Chrysler Corporation. It's really changed ownership a lot of times. First in 1998, it merged the alleged merger of equals with Daimler, which owned the owner of Mercedes. It was Daimler Chrysler until 2006, kind of got spun off to a private equity firm. Then it went through the bankruptcy. Then it was Fiat Chrysler. And then Fiat Chrysler, also known as FCA, merged with Peugeot, and that became Stellantis just under 4 years ago.
Jamie, thank you for that concise explanation. It's almost like you have experience in podcasting. So tell us now about Carlos Tavares and his role at the helm of the company. What happened here?
Yeah, I mean, quick history on Tavares. Super talented executive. He worked mostly on the Renault side of Renault Nissan and really wanted the chance to be a CEO. Felt like that wasn't going to happen under Carlos Ghosn, so he went to Peugeot. They bought Opel from GM, and it had basically lost money for 90 years, and he turned it around and made it profitable and leveraged that to essentially buying or merging with the Chrysler unit. And so Stellantis, is this giant collection of brands. I mean, Fiat Chrysler alone had like 10 brands, and then you add Peugeot, Opel, Vauxhall. It's a lot of brands to wrangle, and they're really spread all over the world. Fourth largest automaker, bigger than GM or Ford.
So let's start with the good. What did Tavares accomplish in his time at Stellantis?
The first 3 years, he made a lot of money for that company. Of course, it was during the pandemic. A lot of most automakers had record or near record profits. Kind of the same for dealers. Suppliers had a rough go of it, but the big brands did really well. And Stellantis especially, because they have two big money-making brands, Ram and Jeep. And they both did terrific work during the pandemic. Stellantis made like $51 billion over those 3 years, the first 3 years of its existence. And then it hit on some tough times this year.
And now that he's gone, a number of reports point to a disconnect between Tavares and the board. What was going on with Stellantis in the months leading up to the resignation?
Yeah, after the profit wheel started to fall off, he really got sideways with the board and kind of nothing was going to be good enough. He had promised these huge double-digit profit margins that they were able to deliver during the pandemic, but aren't really realistic for the long run for a mainstream automaker. But he wanted to push really hard to achieve that. They kind of, they wanted him to meet the goals, but they didn't want him to push that hard. They were frustrated that he had disrupted their relations with unions, with dealers, with suppliers so badly. They clearly just wanted him gone.
And anyone who lives in Metro Detroit knows that dealerships play an important role in the auto industry. So how are dealerships responding right now to the news of the resignation?
Yeah, well, it's a little bit ding dong, the witch is dead, right? They were really frustrated with him. They were, accused him of malfeasance. So they were glad to see him go. There's, in addition, after Tavares left, then an executive named Tim Kuniskis, who had led Ram before, also really tried to shepherd, come up with a strategy for Dodge to get electric and not, lose all its dodginess and lose its Dodge fans, most of all. So he came back out of retirement. He had retired in the summer, very popular executive, very, fiery and spirited. So he's taking over Ram, and that has dealers feeling good too.
You're listening to the Metro on WDET. We're talking about the abrupt resignation of Stellantis CEO Carlos Tavares. He had been the automaker's top executive since the formation of Stellantis in 2021, but had been at odds with the company's board in recent years. Our guest is Jamie Butters, executive editor at Automotive News and host of the Daily Drive podcast. So, Jamie, the search is underway for the next CEO, but an international conglomerate like Stellantis, it doesn't just run itself. Talk a little bit more about who's in charge.
Yeah, in the time being, until they find a new CEO, they've got an executive committee. It's really being led by the chairman, John Elkann. He's, I think, a grandson of the founder of Fiat, the Agnelli family. So he's really the sort of the Bill Ford of Italy, if you will, the scion of the family. And so he's been very active. Most business school professors would tell you that having a committee in place of the CEO is suboptimal. Harder to make swift decisions, but they have been moving quickly to try to repair relations. Like I said, bringing back some key executives and, trying to keep the company on track, but they've got to also be really actively searching for a permanent CEO.
What else would you say the executive committee is trying to prioritize right now to keep that ship steady?
Well, I think they're trying to make sure that operations are going correctly. One of the things that really got Tavares and Stellantis in a lot of trouble was they overbuilt the inventory. Part of the success of the pandemic era was keeping inventories low so that dealers weren't paying, a lot of interest to maintain, trucks on the lot. If you turn them quickly, that's more efficient. It's more profitable. You don't have to have as big of incentives. Stellantis really built out, the Ram and the Jeep supplies. They had, a 100-day supply of some models. So then they had to, shut down factories, and then you're not making any money as an automaker. So, they really need to stay on top of that, keep their incentives competitive, and keep the inventories from getting too out of line.
And you talked about there being these record profits under Tavares and then things changing quite a bit from a financial perspective. So what exactly does the financial footing look like for Stellantis to start 2025?
They're solid. It's not like there's a liquidity crisis or a chance that they will be, gobbled up by somebody for very little. But, it's a tough time. They've had some expensive things to fix, like that inventory problem. I've heard some speculation that maybe a new CEO wouldn't even want to take over until February, after the 24 losses can all be booked and blamed on Tavares, and they can come in and try to figure out how to fix it. But it's also going to be a really hard problem to fix because they have so many brands. A lot of them are national champions. They all have sort of little niches, but do they really pay for themselves? It's a big challenge to wrangle.
And besides inventory, Jamie, is Stellantis facing any other headwinds going into 2025? Like you just said, we heard maybe someone may not want to take over until February. So what are some other things that they can see going into 2025?
Yeah, it's a mixed bag for the industry. Obviously the former Chrysler, the folks up in Auburn Hills, they have traditionally done well when gas is cheap and the economy is strong. And, there's some sense, maybe a Trump presidency would be good for Jeep and Ram if they don't have to as much pressure to electrify, which is a big profit challenge for automakers. And they have these brands that are kind of known for thriving in that world. But they do have some big electric bets that are really coming to fruition next year. We're going to see the Ram Rev, that's the Ram electric vehicle, a pure electric pickup. They're also going to come out with, they call it's kind of a silly name, but the Ram 1500 Ram Charger. And it is what they call an extended range electric vehicle. In a lot of ways, it's just a plug-in hybrid, but it has electric drive on the wheels, but it has a gas engine. So after you go, whatever it is, 10 or 30 miles and you run out of battery, the gas engine kicks on and that charges your battery. So it's electric drive, but it's not purely emission-free. Could be a really popular work truck, but it's going to be interesting to see how Ram navigates this electrification move and if they can, take some business back from the Ford F-150 Lightning.
Jamie, speaking of electric vehicles, I'm wondering how Stellantis stacks up against Ford and GM. And then what about international competitors?
Stellantis is way behind. There's just no other way to put it. That has helped them in their bottom line in recent years because they haven't, you've seen the headlines, Ford losing $5 billion a year on EVs. It's really expensive to build an EV business. It was for Tesla as well, for, losing money for well over a decade before they started making money. So Stellantis is behind. That's been beneficial to them, but they've also been very thoughtful about it, and they seem to have good technology, but we're going to see it in the market coming up.
And Jamie, that's perfect transition because I was recently driving on the road and I saw a car and I said, that's definitely a car that's under the Stellantis brand, but I didn't know what it was, but it was an EV. It looked really, really sleek. So are we going to see a larger push, especially in 2025, from Stellantis into this EV market?
Absolutely. They're really coming to market now. The Dodge Daytona, that might have been the sleek monster you saw on the street. They're just starting to get out. The Jeep Wagoneer S and the Ram Rev. So really iconic brands coming out with their EVs now and early in 2025.
Jamie, before we let you go, we have to talk about President-elect Donald Trump and his discussion about tariffs and how those might impact the big three automakers. Can you give us a quick 101 on that?
Yeah, so if we take it on the surface, massive tariffs against Canada, Mexico, and all of our key trading partners would be very inflationary, very disruptive to the industry. But the other part is he didn't really say he wants to do that or that he wants to do it as an economic policy. He's trying to use it as leverage for, migration policy and drug enforcement. So I think a lot of the thinking is that there may be tariffs, but if there are, they might only be short-lived. I mean, of course, the risk is you throw up big tariffs and the other countries throw big tariffs on us, and it just makes everything really expensive. We'd see a lot less global trade, and I know global trade can be a dirty word with some people, but it helps keep prices down. It has, it's very effective that way. So we could see prices really going up maybe that would only last for a little while, but if it became a full-blown trade war, it would be very expensive for the automakers and for everyone in America.
Jamie Butters is the executive editor of Automotive News and the host of the Daily Drive podcast. Jamie, thanks for joining us on the Metro. We'll talk to you next year if and when Trump's tariffs hit the auto world.
You bet. Glad to do it.
From the WDET newsroom, Detroit police shut down a mobile gas station near McNichols Road in the Lodge Freeway after a clerk allegedly shot a suspected shoplifter. The incident mirrors a similar occurrence at the same station in 2023. Authorities are investigating the circumstances surrounding the shooting.
The nonprofit Raising Voices is urging the public to advocate for the Teach Michigan History Bill package introduced this month in the Michigan Senate. The proposed legislation would require all Michigan school districts to incorporate curriculum on the historic contributions of communities of color. The bills would also require cultural competency training for teachers and create a cultural advisory board within the Michigan Department of Education. That's a lot.
The Michigan Attorney General's office has released its report on alleged sexual abuse and other sexual misconduct by Catholic clergy in the Lansing diocese. The report lists allegations dating back to the 1950s. Nessel says the list of accused include 48 priests, 3 religious brothers, 1 former brother, and 4 deacons. Nessel says the Lansing diocese cooperated in the investigation and submitted some of the names on the list. She says in many cases, prosecutions are not possible because of the statute of limitations, deaths, or victims who did not want to pursue cases. This is the 4th of 7 reports the state intends to issue on clergy abuse in each of Michigan's Catholic parishes.
Coming up at 11, after United Healthcare CEO Brian Thompson was shot and killed in broad daylight, a familiar conversation is back in the public consciousness. How a profit-driven health industry leaves people penniless, sick, and sometimes bankrupt.
Have you ever avoided seeing a doctor or not gotten a prescription filled because of the cost? Have you ever struggled with medical debt? Call and tell us about your experience. The number's 313-577-1019.
Coming up next, nitrous abuse is on the rise. How are young people getting whippets and how big of a problem is it? Stay with us. We'll be right back on the Metro. Welcome back to the Metro on 1019 WDET. I'm Tia Graham.
And I'm Robin Vincent. A new generation has been tapping into an old drug. You've heard about it, maybe had it at the dentist's office, nitrous, laughing gas, or whippets. It's been a popular inhalant throughout history, and research suggests the recreational use of nitrous oxide gas has been increasing over the last 2 decades among young people. Public health leaders say laughing gas is really no laughing matter. And with that in mind, this year, Michigan banned the sale of nitrous oxide paraphernalia, in part because the increase of nitrous abuse has been playing out here in Michigan. Joining us now to break this down is Senior Director for the Michigan Poison Control and Information Center, Dr. Varun Vohra. Dr. Vohra, thanks so much for joining the Metro.
Thank you, Robin, for having me.
So, Dr. Vohra, popular culture has made light of nitrous or laughing gas for a long time, but I realize it's really a public health concern. So, we're going to discuss in a moment what you're seeing at the Michigan Poison Control and Information Center. But first, what exactly happens when a person inhales nitrous oxide? Why is it such a public health concern?
Yeah, great question. So nitrous oxide, like you mentioned, is a laughing gas. It's often used commercially, right? So for whipped cream, people will think of whipped cream, which gives it sort of its aesthetic appearance because of its foaming appearance. It's also used as fuel booster as well for cars. People have probably heard of nitrous before, but where people really get into problems, especially with chronic use. Essentially what it does is it inactivates certain key vitamins, specifically key vitamin B12, which is absolutely necessary for healthy brain and spinal cord health. So people who chronically use, eventually what happens is the vitamin B12 becomes inactivated. So this leads to a whole host of sort of downstream health issues with regards to neural transmission in the nervous system, the central nervous system, and peripheral nervous system. So patients can often present with numbness, tingling, especially in their extremities. They'll have difficulty walking as well. And then eventually, in severe cases, it can lead to frank paralysis. And then recent research is also showing downstream effects when it comes to neuropsychiatric health as well, when it can cause mood changes, cognitive impairment, memory lapse as well. So it can be a very significant physical and psychiatric issue, which can be permanent in often cases. And with resolution and treatment often being pretty incomplete and being over a prolonged period of time.
Dr. Vora, I think the thing that is thrown around casually is this is going to kill your brain cells. Can we just make that sort of blanket statement about nitrous?
I guess it's a little more nuanced there when it comes to killing your brain cells. I think it certainly impacts your, like I said, the nervous system. So again, it's whatever vitamin B12 stores you have in your body, it's inactivating those vitamin B12 stores. So what happens is that it prevents the synthesis of really key enzymes and what we call cofactors that are really essential for the health of the nervous system. So when you think of things that help with the myelin sheath around the neurons, the things that help to transmit neural signals, that is impaired. It can also impair folate synthesis, which is really key for DNA synthesis. It increases the levels and concentrations of certain oxidative stressors, so that can lead to reactive oxidative oxygen species, which eventually leads to cell death. So in essence, yes, it can lead to neuronal cell death, and then increase the risk of cardiovascular effects as well because of that oxidative stress. So people could be at increased risk of stroke, potential heart attack, blood clots, etc. So there are a whole host of different downstream effects associated with specifically chronic nitrous abuse. And we're seeing a lot of cases where people will use tanks and tanks of these things daily, on a daily basis for months. And that's where we get really concerned because this can have, like I mentioned, often permanent effects.
Okay, we're going to get into also what you're seeing at the center, I promise.
Mhm.
One more thing, though. I'm wondering how addictive you would say nitrous is.
I think it certainly can be, and we're often, what the data is showing is that the comorbidity is often associated with people who present to the emergency departments with nitrous abuse or nitrous oxide misuse. They often have dependencies on other products. So the issue here is that nitrous oxide, it is technically legal. It's commercially available. You'll see it at vape shops. You'll see it at gas stations, convenience stores. You can buy it online. So people think that it's legal, so that they might think that it's automatically safe, which is sort of the myth that we want to dispel. It is very quick on and off, meaning that it gives you a really quick euphoric sensation and quick high, but then it disappears just as quickly, so within minutes. So that's why people like to use it, because it doesn't necessarily make you inebriated per se for prolonged periods of time, like something like alcohol might, where it takes time to wear off. But certainly, I believe there's certain a dependency component to it, which often might help stimulate more chronic abuse.
And Dr. Vora, we know that recreational use of nitrous has been increasing over the last few decades, and this is particularly among 19 to 29-year-olds. So talk about what you're seeing at the Michigan Poison and Information Center.
Yeah, so I mean, we've done a pretty extensive, syndromic surveillance, especially from our Center of
Can
Michigan
you
Boys.
say what that is? Syndromic surveillance. That sounds very high tech.
Very technical, right? So it's essentially what we call pharmacovigilance or toxicosurveillance, basically meaning that a surveillance system to see where and when certain overdoses are occurring or when they're reported, whether it's that's to the Michigan Poison and Drug Information Center, the state, we're the only state poison center in Michigan, whether it's to emergency departments across the state, EMS, emergency medical services responses as well, where we were able to track those with basically correlating those data repositories and essentially seeing where the signals are, where there's could be, where there could be early warning systems, where they're occurring, whether we can target those areas upstream to hopefully prevent or mitigate at least the effects of misuse and overdose. So we get a good sort of statewide picture as best as we can. So what I will say with Poison Center data, we rely often on passive self-reporting, voluntary reporting, especially from providers, also callers themselves or patients themselves who call in and want to know more, or if they're experiencing symptoms and they want to know what to do. That's invariably going to be an underestimation of the total statewide burden because we're not capturing every single call, but that's where the correlation with other data repositories like the EDs and EMS really, really helps to kind of paint that broader picture and broader strokes. So from our center specifically, we've gone back well over a decade and we've seen a significant rise, more than about 4 to 5 times since around 2010. And specifically, it seems to be increasing recently. So going back to 2022, from 2022 to 2023, there was over 130% increase, at least in
A hundred
ED
and
emergency,
sorry.
30% increase
Okay.
in emergency department visits where nitrous oxide was implicated. So that's really concerning. So, up until late 2023, the numbers had already surpassed all of 2022's. So we're starting and we're seeing more and more of that increase. And that's what we want to continue to surveil, right? So we're keeping track of those cases in conjunction with trying to work or collaborating with our state health colleagues to see, where these are occurring, what the prevalence and the incidence is, and what we can do about it in terms of getting that messaging out, like you mentioned with the state legislature.
That's a huge increase, 130%. And that's over what, the last 15 years, you'd say?
Yeah, about between, I'd say 13 to 15 years. And the 130% increase was specifically, going from 2022 to 2023. Within that year alone, we saw an over 130% increase in emergency department visits related to nitrous oxide misuse.
So what are some reasons for the increase? Does it have to do with access, even though paraphernalia has been banned? I'm wondering where people are getting the tanks from. Is this medical grade gas, food grade? What's going on here?
Yeah, so that's a really good question. So with the banning of the paraphernalia, so the paraphernalia, just for the listener and the audience, is it's typically associated with what we call a cracker. So the cracker is basically a puncturing device which will puncture the whippet, which is sort of a steel canister where the nitrous oxide is contained. So to be able to access it, they'll puncture the canister and then release the gas slowly into something like a balloon, where they can inhale the gas directly from the balloon because the nitrous oxide, it's a very cold gas, and if you inhale it directly from the whippet, it can cause frostbite injuries and oral injuries, which can be very, very uncomfortable and painful. So people have become sort of sophisticated with use through these sort of paraphernalia devices. But the problem is that combined with that is there's now availability, like you mentioned, open availability in gas stations, vape shops, convenience stores, but it's also being marketed by wholesale manufacturers and distributors as independent entities. So you can buy like a tank or a tube, whatever you want to call it, of nitrous oxide marketed by a specific company for the purposes of recreational use. So they don't necessarily need to rely on getting these whippets as much anymore because they can purchase these independent products online or at the various locations and vendors which is a huge concern for us because it's being marketed actively on social media, and you'll see it on Reddit posts and sub posts about people using it and where they're getting it from, as well as them being sort of flavored as well. So to entice sort of the younger generation, the colors and the packaging and the graphics clearly seem to be catering towards sort of that younger generation of, say, college students and young adults.
You're listening to the Metro on WDET. We're talking about the rise in recreational nitrous oxide use. Dr. Varun Vohra of Wayne State is on the line helping us understand how we're dealing with the issue in Michigan. And Dr. Vohra, that makes me wonder about enforcement when it comes to cracking down on people selling these tanks. What do you know about that?
Yeah, so I mean that's sort of the next sort of phase that I would say, in terms of we made good progress with at least banning the paraphernalia associated with recreational use of nitrous oxide. But if we want to mirror other countries and nations that have taken it a step further with inhibiting or prohibiting the sale of nitrous oxide to minors, so people under 18, or they'll restrict sale times, so between certain times of the day, say between like 10 p.m. and 5 a.m. Also restricting visibility of accessible nitrous oxide to the public in retail stores, making it less apparent and overt, because a lot of times, at least locally, what we've seen is we've done sort of random quote unquote audits of certain locations and have seen it front and center, right? As soon as you get in, you'll see a bunch of tanks or tubes lined up, which is very overt. Other places have, or at least countries have, pursued legislation of enforcement with failure to display notices on the premises about the penalties associated with selling to minors. So those are kind of things, those are examples at least of what sort of next steps, at least local legislation and statewide legislation can pursue to prohibit at least sales geared towards recreational use, with being mindful, of course, that nitrous oxide is still used commercially, and there are legitimate commercial uses, obviously medical uses and in dental settings, specifically, but also for the commercial uses, like with in the culinary industry, right? So we want to be mindful of that, but that's sort of the tug of war that that exists with finding that balance to mitigate and prevent sales geared towards recreational use, especially among youth.
Dr. Vohra, so what you're saying, the accessibility, the legality of this drug really adds some complexities when it comes to trying to mitigate abuse. And that makes me think about some reporting I did earlier this year, looking at another drug, at cannabis, and its poisoning among kids. And the reporting that I did was informed by some of your work. Back in the spring, you had told me about some data you collected at the Michigan Poison and Drug Information Center. And I just want to briefly look at that data and have you tell me what things look like now. So what we had discussed before was that from 2020 to 2022, among children ages 5 and younger, the center had seen a nearly 75% increase of unintentional youth cannabis ingestion. And then among kids 4 to 13, that increase was 60%, and that was between 2020 to 2023. Can you speak to the number of calls you've been seeing in the latter half of this year since we last spoke?
Yeah, no, it's a great question. And we have continued to track these cases, especially in young kids, like you mentioned, say under the age of 6 years old. And what we've been seeing is sort of a linear increase. So in 2023, we had well over 300 reported case exposures, again, to our poison center specifically. So like I mentioned before, taking that in the context of this being an underestimation of the statewide burden, right? We're not capturing every single case, but it can be used as a bellwether for sure. And in 2024, up until December 1st, we've already exceeded 2023's numbers by about 30 to 40 cases, still not an insignificant amount. And because we still have about half the month left till the new year. So we are continuing to see that increase. And I think messaging and education and outreach are imperative in helping to mitigate these exposures going forward, because we certainly don't want those numbers to continue to rise.
Dr. Varun Vohra is the Senior Director of the Michigan Poison and Drug Information Center. Dr. Vohra, thank you so much for joining the Metro.
Thank you, Robin.
Coming up next, after United Healthcare CEO Brian Thompson was shot and killed in broad daylight, a familiar conversation is back in the public consciousness. How a profit-driven health insurance industry leaves people penniless, sick, and sometimes bankrupt. The phone lines are open and we want to hear from you. Have you ever avoided seeing a doctor or not gotten a prescription because of the cost of healthcare? Have you ever struggled with medical debt? Call us. It's 313-577-1019.
This is WDET-FM, Detroit Public Radio, your connection to news, music, and conversation.
This is The Metro on 1019 WDET, Detroit Public Radio. I'm Tia Graham.
And I'm Robin Vincent. It's the second hour of The Metro. This is where we go deeper into the pressing issues that affect our region. One of those problems is about health care. And the conversation sprung from a very sudden death. A few weeks ago, the CEO of United Healthcare, Brian Thompson, was shot outside the New York Hilton Midtown in Manhattan. The alleged murderer is 26-year-old Luigi Mangione.
In the following weeks after the murder, Mangione has been celebrated as a kind of vigilante, someone who's allegedly stood up to a greedy healthcare corporation that is starving people of care or charging impossible rates for it. We do not support that reaction at WDET, but the response speaks to something that affects everyone: healthcare. We all need it. Regardless of how much money we have, we will all get sick at some point. And to many, the healthcare industry is unjust. It means that pre-existing conditions are sometimes not covered. It means that deductibles are too high and people have to pay out-of-pocket cash for the care they need.
Healthcare, many argue, is not a market good, like a chair or a television. It's not something we can go without. Rather, it's a necessity. Something that if people don't get, they could die. This hour, we want to discuss medical debt and America's healthcare system more broadly. And we want to hear from you. Have you ever avoided seeing a doctor or not getting a prescription filled because of the cost? Have you ever struggled with medical debt? Call and tell us about your experience. 313-577-1019. Now, we want to start this conversation by understanding how we got to this moment in time.
America has a patchwork healthcare system. Older and poorer individuals get covered via public insurance programs like Medicare and Medicaid. Others get it through their workplace, which provides a private insurance option. And for those who don't get assistance from an employer, some get covered by Obamacare. And still, more people aren't covered at all. So while medical innovation ranks well in this country, things like coverage, quality, and cost for all pretty bad compared to other rich nations. All this, given the fact that we pay more than anyone else for health care.
So how did we get here? And why do we pay so much and sometimes get so little. Here to discuss this is Dr. Elizabeth Rosenthal. She's the senior contributing editor for health news analysis at the Kaiser Family Foundation. She's also the author of An American Sickness: How Healthcare Became Big Business and How You Can Take It Back. Dr. Rosenthal, welcome to the Metro.
Thanks for having me.
So we have this big disjointed system where both public and private insurers are involved, and still about 25 million people don't have health insurance. How did we get here in the first place, Dr. Rosenthal?
It's a long and sordid history, actually. And, I think one of the things you mentioned before, I just want to tweak a little bit because Obamacare did a number of important things, and one of them was it said that you can't be denied health insurance or have to pay higher rates because you have a pre-existing condition. Now, we see at KFF Health News, insurers try to get around that, but that is illegal if anyone is doing that right now. So that is probably the single biggest win of Obamacare. Going back to the history, basically, to do a little time capsule here, insurance started, initially it wasn't really to cover health costs. It was to cover workers' lost wages if they were sick, because if you're in the hospital, you couldn't work, right? Then when there started to be more in the early 20th century, things that medicine could actually do, a teachers union in Texas made an arrangement with a hospital system to pay a day rate for hospitalizations, right? That was kind of the first model of health insurance. But, the years go by, and then the next touch point is after World War II, there was the labor shortage, and companies realized that if they offered health insurance, that was a way to get workers to come to them. So more people got insured. Then next touch point is 1963, where Medicare happens. And so suddenly there's more money that people can make from charging in the system. But Medicare largely has fixed rates, so it's not a big income yet. But then what happens in the real kind of point where it flips that I write about in the book is in the 1990s, there's this movement, the HMO movement, and hospitals at that point, they're poorly run. They have maybe one or two administrators, and they work on really thin margins, and the hospitals are really struggling. So what do businesses do that are really struggling? They call in the consultants, and these are business consultants, right? McKinsey, First Boston, they all have big healthcare consulting practices now. And the consultants look at the hospital spreadsheets and say, hey guys, why are you leaving all this money on the table? If you just bill better, you can make more money. And of course, when I worked as an ER doctor, I came with the hospital, right? I was on a salary. Now you go to an ER and the bills are so disaggregated, right? All of us know that. You pay separately for the doctor, you pay for the IV bag, you pay if they put some oxygen up your nose, if you get stitches. Everything is billed separately. It's like what we all see in the aviation industry, but on steroids. And that has just gotten worse and worse and worse.
Dr.
So,
Rosenthal, forgive me for jumping in here,
yeah.
but I'm struck by this notion of consultants coming into the picture. How did that happen in the first place? Why were they able to enter the healthcare space?
Well, they were asked, and they were good at going into chicken processing plants and telling them how to be more efficient. So the hospitals asked them, and also they kind of lured the hospitals with deals like, and this was one former consultant told me, oh, we'll help you improve your ratings in the U.S. News Hospital Survey if you let us come in and do this. And they kind of get a cut of the improved profits. So hospitals went from operating on really thin margins to much cushier margins, and that includes what we think of as not-for-profit hospitals that basically act the same as for-profit hospitals today.
Dr. Rosenthal, why does America, unlike most other rich countries, not have a public option for everyone? I mean, you've been describing just how healthcare here has become this truly big business. Why is there only a public option for the folks who are of low income and elderly?
Yeah, that's one of the big whys of our healthcare system, and I think that has to do with politics. Different different presidents have proposed a public option for decades, literally decades, and it goes nowhere. You might remember that was part of Joe Biden's campaign when he ran for president, a public option, as opposed to Medicare for all. And it just never goes anywhere because there's not the political will, in part because the healthcare industry is the biggest lobbying force in DC. I mean, that's hospitals, that's pharma, that's insurers. There's just no will to change a system that is so powerful these days. I mean, here in New York State, where I live, the Greater New York Hospital Association, they are one of the biggest lobbyists, both in D.C. and at the state level. So, it's really a hardship to turn. And when I hear you talk about it, look at this. We are talking about not a healthcare system as we used to do, but a healthcare industry. It's not a system, right? It's a bunch of big businesses, and poor patients are left struggling in this land of the giants to just get the care they need. And they don't.
You're listening to The Metro. We're speaking with Dr. Elizabeth Rosenthal, the senior contributing editor for the Kaiser Family Foundation. We're talking about how our healthcare system became the way it is today. And we also want to hear from you. Have you ever avoided seeing a doctor or not gotten a prescription filled because of the cost? And have you ever struggled with medical debt? The number is 313-577-1019. We're going to go to the phone lines now. We have Adam in Detroit. Adam, thank you for joining us on the Metro.
Hey, good morning.
Good morning. Yes, yeah.
Yeah. I just wanted to talk about, so I have ADHD, right? Mm-hmm. And I've had it since I was like 5 years old. And I've been taking a prescription for it since 5. That's kind of early, but I mean, my parents worked with like biofeedback and everything like that. So it wasn't just medicine. But I'm freshly 26 now, right? And we all know after 25, you get kicked off your parents' insurance. So trying to figure out the whole, okay, my company has insurance, what is actually covered and what isn't covered was a very big struggle because my company is located out of Utah, and that they don't cover anything. Like, they don't cover anything that I actually need. Like, what I will need is Adderall, basically, right? But what they cover is the generic version. And when right now there's a shortage of amphetamines in the United States, which is really crazy. So, like, I'll go to the pharmacy after getting this doctor's visit that was really hard to schedule, and then I'll go from the doctor's visit to the pharmacy, and they'll be like, oh, we don't even have that. So I've just wasted a bunch of time, and I don't know what to do about it, but that's one thing I'm figuring out right now.
I was going to say, Adam, is there an option for you to go to other places, or right now there's truly just that one option that you have?
It's like nowhere, like you'll go to Costco, CVS, everywhere is like, sometimes if you go to like family doctors or whatever, they'll be like, oh, I got 6 or 7 of those pills that you need. But still, even whenever they have the Adderall, it's not covered by my insurance. So they'll be like, oh, we don't have the generic. We have 6 of this Adderall, but it'll be $500 for 6 pills. And I'm like, I'm not doing that. That's crazy. So, yeah, that's just something I'm figuring out. So, I mean, hopefully the shortage has been going on since 2022. So that's also on top of figuring out how to pay for insurance and figuring out if I even need my company's insurance, or should I just try to get my own, or I don't know. But I think that's something I'm figuring out at 26. So.
Adam, thank you so much for calling us on the show this morning. And Dr. Rosenthal, how often is it that people's drugs aren't covered, and why does that happen, especially as we're hearing what Adam's been going through since 2022?
Yeah, Adam's story brings up so many problems with the system. I mean, the first one is we're actually doing a project now on something called the 26 cliff, when people fall off their parents' insurance and have to kind of, wander in the forest of U.S. healthcare and try and figure things out. And Adam Wright has a job. He has company insurance, but a lot of insurance is not very good and doesn't cover a lot of things, as we all know. And these old drugs, like, why is an old drug as expensive as Adderall is? It's because, in this country, we don't regulate drug prices in any way, or we've started to, like, take baby steps to do it for Medicare, but most other countries in the developed world negotiate drug prices for everyone in their country, and we do not do it here. So, drug makers charge whatever they can get, right? And meanwhile, patients like Adam go without because they can't afford it.
Dr. Rosenthal, you are a physician. I'm wondering what you've noticed while working as a doctor about the big business of healthcare.
Oh, I am. In my book, I said I kind of had a ringside seat to the transformation because when I was a doctor, I'm going to sound like a dinosaur now, which I stopped being in the mid '90s. I was working in an emergency room. None of this was a problem, really. People who had insurance, they paid their premiums and things were just paid for, and drugs weren't that expensive. A moment I like to remember in history, I was working in an ER in New York City, and during the AIDS crisis, when the first effective drug to cure AIDS, or not to treat AIDS, AZT, came on the market. It was priced at $10,000 a year, or about $700 a month, and everyone said, no drug. There were op-eds in the New York Times that said that's immoral. No drug should be that expensive. And now, $10,000 a year, $700 a month. That's insulin. That's thousands, if not tens of thousands of drugs. So our benchmark for what's expensive has changed so very much. 6 pills for $500. That's crazy.
Oh, wow, Dr. Rosenthal. Yeah, I mean, there seems to be just no excuse when life-saving medication is out of reach for the people who need it. I do want to bring up a counterpoint, though. This is something that I've heard when I've traveled abroad to other countries, and I'm bemoaning, criticizing the healthcare system in the U.S. And I have heard the argument from people who will say, yes, but America's medical system is really good on innovation because it has a lot of private incentives for, say, pharmaceutical companies and private entities to invent new medications, to innovate when it comes to medical technology, and that this kind of innovation is one of the really good parts of the American system. What do you make of that perspective?
Well, there's a little seed of truth in that. There are sometimes medicines, very expensive ones, which we can get here if you have the insurance that's good enough to cover them, that people in other countries have to wait till the National Drug Board can, negotiate a reasonable price. But the innovation argument, I think, fails in that studies have seen that, yes, we have higher prices, and that might lead to, one new drug every 20 years or 30 years that wouldn't have been developed otherwise. But, many of the new drugs on the market aren't really innovative. They're kind of copycats of drugs that are already there. And yet all of them charge a very high price. You would think if there were 5 drugs that do the same thing, there would be competition and the price would come down. But in pharmaceuticals, there's this thing called sticky pricing, where a new one comes on the market, it charges a higher price, and all the other pharma makers look around and go, oh, we could do that too. So the prices are, to me, they're just unconscionably high. And whatever innovation we may get, look, our life expectancy is going down in the U.S., so compared to other countries. So clearly, all that innovation isn't helping people the way it should, right?
Right. Something needs to be fixed here. I do want to bring up one other argument and have you respond to it just as briefly as you can. And that is that people can see doctors really quickly, which isn't true in systems that rely on the government to provide health care, or maybe isn't always true. I'm don't want to speak with that level of certainty. But what do you say to those folks?
Well, I think that used to be true. When I was a reporter at the New York Times in the 90s, I did a story about wait times in Canada versus the U.S. for heart surgery, which, P.S., is a lucrative procedure. So, I think there's a lot of fallacy in that argument, in that if you want to get something that's profitable, like a hip or knee replacement or a cardiac cath, you can be in the procedure room next week, if not tomorrow. If you want to see a primary care doctor, boy, the waits are long. If you can find one, you want to see an endocrinologist, forget it. The waits are crazy. You have a kid newly diagnosed with type 1 diabetes, you're going to wait a long, long time in most cities, because we value the profitable procedures, right? And not the, sorry, there's a siren going by.
How ironic.
I know, medical, and here we are.
Hi, we view the profitable procedures you can get really quickly. Unprofitable things, good luck. The waits are long, if not longer, than in other countries.
Dr. Elizabeth Rosenthal is the senior contributing editor for the Kaiser Family Foundation and the author of American Sickness. Dr. Rosenthal, thank you so much for joining us on the Metro.
That was a well-placed siren that
really
we were
was.
hearing there in the background. Next, we're going to hear about what healthcare access looks like here in Southeast Michigan. And we want to hear from you. Have you ever avoided seeing a doctor or not gotten a prescription filled because of the cost of healthcare? Have you ever struggled with medical debt?
Call us and tell us your experience at 313-577-1019. And coming up, over 40% of working Americans struggle to pay their medical bills or paying off medical debt at all. We'll zoom in and examine the problem in Southeast Michigan.
Stay with us. This is the Metro on 1019 WDET, Detroit Public Radio. I'm Robin Vincent.
And I'm Tia Graham. It's the second hour of the Metro. This is where we go deeper into the pressing issues that affect our region. As we've been talking about America's healthcare system is unique, especially when compared to other rich countries. And in America, we really have an issue with medical debt. More than 40% of adults have some form of medical debt. Some states have enacted policies to ease the pain of medical debt, but Michigan really hasn't done much to solve the issue.
However, a few counties in Southeast Michigan, Oakland and Wayne, are working with a nonprofit to eliminate hundreds of millions of dollars of medical debt for their residents. How has that been going, and what more can be done to improve healthcare access at a local and state level? Dr. Abdul El Sayed is here to discuss all of that. He's the director for the Department of Health, Human and Veterans Services for Wayne County. Dr. El Sayed, welcome to the Metro.
Thank you so much for having me.
Of course, of course. So why did you decide to work with the nonprofit RIP Medical Debt? The goal is to erase hundreds of millions of dollars of medical debt. Is that right?
Yeah, that's right. So County Executive Evans understood that we had a real responsibility not just to take on the pandemic, but also to address the broken healthcare system that left Wayne County residents struggling worse and with more financial consequences from that pandemic. And to that end, we realized that there was an opportunity for us to step in and take on the scourge of medical debt for our county. We identified the fact that we ranked number 8 for medical debt in the entire country, and that this was an opportunity for us to be able to wipe clean $700 million of debt. Now, folks think of debt as being something that an individual holds, and that's true to some degree. But when $700 million of debt is held in your county, that's an albatross on the whole county's business. And you think about the number of cars that go unbought, the number of homes that cannot be afforded as a function of the fact that people are worried about being able to pay down this debt, and the fact that the number held in debt is really just it's a function of this very odd math. The cost of healthcare is negotiated in a very opaque way between healthcare providers and health insurers. And so when people take on medical debt, the actual value of that debt isn't the nominal value, what it says on a piece of paper. It's the value that somebody's willing to buy it for. And what happens is when a healthcare system can't recoup on that debt, they end up selling it to a debt collector. And that debt collector is basically making a bet. They'll say, look, we can buy this for like a penny on the dollar because the probability that it ever gets paid is so low. And we hope that we can collect on the whole value. And if we can collect on even 1%, it makes that worthwhile. Meanwhile, people are getting calls, they're getting hounded, they're going without the basic needs of their lives because of that debt. And we realized that RIP, or now called Undo's solution, was basically to say that rather than sell this to a debt collector who's going to hound people for the simple fact that they got sick and needed health care, why don't we just buy it and wipe it clean? And so we realized this was an opportunity for us. County Executive Evans said, let's jump on it. And so we did. And so we're very excited about the potential here.
And honestly, that's one of our follow-up questions is about the way that the inner mechanisms there at RIP Medical Debt actually work, and how, and that was going to be one of the questions truly was, so can't people, once their debts, once their medical debt is sold off, they can just kind of figure out a way to get it written off, but you all cut that out for the person and you actually do it yourselves. So if you could just talk about stepping in with RIP Medical Debt and the work that you all have been able to do.
Yeah, so I was really excited to get to host the CEO on my podcast, America Dissected, and we talked specifically about the idea for this. This is an organization that's been working with local and state governments around the country to take on this debt, and they were really fortunate to get a very, very large grant from McKinsey Scott, and so it really helped jumpstart what they do. So basically what happens is the county says, look, we can spend $5 to $7 million and we can buy debt for pennies on the dollar. And it's a win-win-win. So the healthcare company, they get money that they probably would never have otherwise gotten without having to hound their patients to the ends of the earth. The county wins because we don't want $700 million of debt in our county. We don't want people to have to go without making very simple decisions that benefit themselves and their families because they got health care when they got sick. And for those folks, the win is obvious. They can go about their lives freely without having to worry about getting a call or getting hounded, watching their credit report go into the trash, and be able to live their futures knowing that they no longer have to worry about this. And so it really is a win. And I got the opportunity to testify before the U.S. Senate on a hearing specifically on this issue. And one of the interesting things that came up is that Wayne County, although we were ranked number 7, if you think about where we fit within the broader problem nationwide, and I know you were just talking to the expert Elizabeth Rosenthal, who's thought a lot about this, there are $225 billion of medical debt out there. That is more than the GDP of most of the states in the United States. The fact that this is not part of a bigger broken system is undeniable. And we need to also be thinking about what we do to take on that system and fix that system. And so we're doing what we can as a county government to address the consequences of the system. But we also understand that we need a solution. that takes on the bigger failures of our broken healthcare system.
I mean, we're just one county in all of southeastern Michigan that we're talking about that you all are tackling. Wayne County, it's amazing to hear the number of top 8 in the country in terms of medical debt. The state of Michigan is. So how's it been going thus far? How many people in Wayne County have had medical debt erased, and how many people could be helped with the program?
So we've just entered into this relationship, and we hope to have some very good news very, very soon here. We are looking at potentially wiping down upwards of $700 million held by 300,000 county residents. If you think about that and you do the math there, you think about the families that are helped. You're talking about probably 40% of households in the county. And so this is an issue that touches folks broadly. And even if you're not somebody who holds medical debt, if you engage in commerce in this county, the high probability is medical debt is affecting you because it is supplanting the ability to go and engage, to go buy things, which is, of course, the lifeblood of our economy. And so this is something that as a county we struggle with, and frankly, as a nation, we struggle with.
You're listening to The Metro on WDET. We're speaking with Dr. Abdul El Sayed, Wayne County Director of Health, Human and Veteran Services. We're talking about the cost of health insurance in America, and we want to hear from you. Have you ever avoided seeing a doctor or not gotten a prescription filled because of the cost? Have you ever struggled with medical debt? Call and tell us about your experience. The number is 313-577-1019. I'd like to turn to the phones now. Medea, are you there?
Yes, I'm here.
Hi, thanks for joining us on the Metro. Talk to us about medical debt, if you would.
Yes, hi, I'm Madiha Tariq. I'm the Deputy County Executive at Oakland County and, been working with Dr. El Sayed as a partner. And, I just wanted to chime in and say that really medical debt, if we really want to make an impact on the financial toxicity that disease causes in our society, it really, and especially in our region, we felt very strongly at Oakland County that this has to be a regional effort. So we've been working closely with Wayne County, and we do have we also have invested about $2 million in ARPA funds that are the American Rescue Plan dollars that are going to be helping to eliminate about $200 million in medical debt. In our county, about 114,000 families are impacted by medical debt. So very similar to what Dr. El Sayed said, this is an issue that impacts not just our families that are in need, but also our economy. It's got ripple effects that impact pretty much every person that lives in our community. And one of the things I'll share is that we have been fortunate enough to secure an agreement with some of our hospital and provider partners, and later next week, about 14,000 residents in our county will be receiving letters that show that their medical debt has been erased, and that would equal to $9.1 million in medical debt, and we're very excited about that.
$9.1 million. Medea, I'm wondering how many people are getting care via a private insurer versus Medicaid or Medicare in Oakland County. And then Dr. El Sayed, I will ask you the same question.
Mm-hmm. Oakland County, I would say, so if you think about people who are, up to 4% of 400% of the federal poverty level, a little over 115,000 residents are in our lowest, in the lowest poverty line. So that means that if you think about Medicaid, we're talking about a pretty significant percentage of individuals that fall in that. So, this is impacting all kinds of families, not just it's working families. It is, your teachers, your, people who work in the fire station. It's not just there's this image of who uses Medicaid, and I think that also needs to be kind of demystified. It's all of us.
That's right. That's right. Medea, Tariq, thank you for reminding us that, yes, no one is immune to this issue, really. You are the Deputy County Executive in charge of Oakland County's Health and Human Services and the Public Services Department. Medea, Tariq, thank you for giving us a call here on the Metro.
Thank you so much for having me.
Dr. El Sayed, so I want to ask you that same question about what healthcare access looks like in Wayne County. How many people are getting care via a private insurer versus Medicaid or Medicare?
Yeah, well, first I just want to thank Medea and their team in Oakland County for their leadership as well. It's great to know that our partner county to north is leading on these issues as well, and grateful for their leadership. It's interesting. We often think about people who can't afford their health care as being consistently on Medicaid. And just to explain here, sometimes people get Medicare and Medicaid mixed up. Medicare is the federally funded, federally operated health insurance program for seniors, people over 65, and some with certain disabilities. That's care. We care for our seniors. Medicaid is the health insurance program that is state operated but federally funded for lower income people. And actually, people on Medicaid tend not to accrue as much debt. It tends to be lower income people who are not Medicaid eligible, right? And those are the folks who tend to have the most out-of-pocket cost because they're stuck in very high deductible health insurance plans. And I just want to explain something here. When we think about health care, it's really complicated, but it really boils down to two types of institutions. You have healthcare providers. They're the folks you go to actually get healthcare. They include clinics and hospitals and even pharmaceuticals who give you medicines that you need to get healthy. On the other side, the jargon term is payers, but that's really a jargon term for insurance companies. Insurance companies exist in theory, right? The operative part of the word insurance is sure, to protect you from the financial consequences of ever getting sick, right? But what has happened over time is that we have both providers and payers who all operate for profit in our country. And so everybody's trying to get more and more of that dollar out of who? Us, the patients. And we tend to think of ourselves as customers, but in our system, we're not actually customers. We're the reason a financial transaction happens between a payer and a provider. And if you think about that, that doesn't make us the customer. That makes us the product. We are the reason why a financial transaction happens. Everybody's trying, though, to get as much of that dollar out of us. The way insurance companies make money is to maximize the delta, the difference between how much money you pay them either every month or every 2 weeks, or when you actually have to get the health care that you thought you paid for in the form of a deductible or a copay. And they have to increase that and then minimize the amount of money they actually pay out to provide health care to those providers. And the bigger that delta, the more money they make. But of course, the worse for you because now you have to fight your insurance for a thing you already thought you paid for. It's like, imagine you pay Netflix every month and then you go to watch, you name the top Netflix show now, and all of a sudden, right, like you're on episode 5 of Bridgerton, and then all of a sudden it's like, okay, $19.99 to watch this. That's how a deductible works. That's the idea. And you're like, I paid every month for what? So I had to pay $19.99 to like watch my show? And that's how, unfortunately, our system works. And so it's those out-of-pocket costs that tend to yield those medical debts because people don't see them coming. And people think they're insured until, of course, they actually have to get the health care they thought they already paid for. And then that $19.99, in this case, $3,000, $5,000 hits them, and they realize they can't pay.
I literally had the same feeling, turned on Amazon Prime, and I had to pay extra for no commercials. And I thought to myself, I already paid for it.
Right.
So why do I have to pay extra? So that's the perfect analogy. I hope people understood that. You explained it like I was 5 years old, so thank you. So let's go back to the phone lines. We have Mark in Windsor. Mark, what is on your mind?
Well, I wanted to just get the idea across that there's a lot of good work being done, and I'm really excited, even though I'm a spectator in this situation for the folks in the U.S., that this debate has come up under, somewhat tragic circumstances with the killing of that CEO. But, this is a discussion that is long overdue. And here in Canada, I'm 63 years old, almost 64. And since I was about 4 years old, I haven't had to pay for anything. And I paid taxes, and I have a doctor, and I've had a doctor my entire life. And a lot of folks, that don't live in Canada seem to think that, either we're somehow socialist or something like that, if you think of the extreme folks, or that our system doesn't work. And it has its challenges, and there's this creeping privatization that is coming in as we get more conservative right-wing governments coming in, and they want to take care of their friends in the private sector and delist things, right? But still, it works quite well for most people. So I'm glad to see that you folks are working hard on this, right? And but ultimately that debt, that loss is borne by the clinic or by whoever that provides that service in the first place.
Hey, Mark, really quickly, I want to ask you a question before we let you go, Mark. What's stopping, in your opinion, Mark, what's stopping America from adopting Canada's system, which has more benefits that we've been seeing?
Well, I mean, it's a for-profit system, and ultimately, as the gentleman before said, we're going to maximize profits, and there's a go-between. Basically, you've got somebody who's almost like in a rent situation, where they're the landlord over your health care, and they're paying, you're paying them, right? They're just, skimming off the top. And this is the thing. I know that people need to buy insurance. I don't need to buy insurance. Right now, my employer does, buy supplemental insurance. I'm fortunate that I've got that, but ultimately, if I didn't, I would get basic care.
Mark in Windsor, thank you so much for calling in this morning. And I want to say, bring in Dr. Al-Sayed. What's your take on Mark's thoughts? And as well, how would you expand on that?
Yeah, so I really appreciate him chiming in because, to collectivize Mark's experience, in Canada, the cost of healthcare for the entire country is nearly half of what we pay here in the United States. So we pay 18 to 19% of our entire economy on healthcare. They spend about 11%. They live on average 2 years longer than we do. And in survey after survey, they're happier with their healthcare. And so to me, right, proof's in the pudding. The crazy thing is my office overlooks Windsor. And it's nuts to me that the small body of water is the difference between the existence of medical debt on our side and the idea that medical debt is like this abomination on their side. So we could do better. The fact of the matter is, if you look at the money that is spent by sector on lobbying our government, the number one and number two industries that spend on lobbying are pharma and insurance. Collectively, them and then healthcare providers who come in at number 8, they are healthcare. And so there's a lot of money that is spent to manufacture a consensus that tells us that we cannot do what Canada does. And the reality of it is most people, when they live in our country, they look at what they have and they say, I guess it's the best we can do, right? And we're constantly told that we're number one. But really, when it comes down to it, when it comes to life expectancy or maternal or infant mortality, we're like not even in the teens. And we could do so much better. This is a choice.
Dr. Abdul Al-Sayed, Wayne County Director of Health, Human, and Veteran Services, thank you so much for joining us on the Metro.
Thank you for having me.
We want to hear from you. Have you ever avoided seeing a doctor or not gotten a prescription filled because of the cost? Have you struggled with medical debt? Call and tell us about your experience. 313-577-1019.
Coming up, we've talked a lot about the problems plaguing our healthcare system. Next, we'll take a look at some of those solutions. You stay right there. This is The Metro on WDET-FM, Detroit Public Radio. I'm Tia Graham.
And I'm Robin Vincent. It's the second hour of The Metro. This is where we go deeper into the pressing issues that affect our region. People with medical debt, as we've been talking about, deal with a lot of challenges. They're much more likely to forego needed medical care, skip a test, a treatment, or follow-up care. or they might not fill a prescription even due to the cost. That's according to Kaiser Family Foundation's Health System Tracker.
So, what are some ways to repair a system that is doing the opposite of its goal and keeping people sick? David Kendall has some ideas on how to improve healthcare in America. He's the Senior Fellow for Health and Fiscal Policy at Third Way, a think tank that champions modern center-left ideas. Welcome to the Metro, David.
Glad to be here. I'm excited about your conversation this morning. It's been very interesting so far.
Thank you. And bringing you into the conversation now, David, most people who owe medical debt owe less than $2,500. So why is this the case?
Well, a lot of people who have medical debt also have healthcare coverage. And as Abdul was talking about, the deductibles are very high for a large number of people. And what that means is that before your insurance kicks in to pay for your health care, you have to pay out of pocket to meet the deductible. And this could be anywhere from maybe $1,000 to $2,500. So for a lot of folks, that just puts healthcare out of reach. But sometimes they go into debt instead to get the care, and that's where they get into trouble.
And as briefly as you can, David, what are deductibles for folks who may not truly understand, and how do they work?
Yes, great question. It is perplexing, especially if you haven't needed to use your health care. But it's similar to what you have on your auto policies for insurance as well. So for instance, you might have coverage for your car, but if you are in a collision, you might have to pay, say, the first $250 out of your own pocket. And that's the same as it would be for healthcare. Like if you had to go to the emergency room, a certain portion of that healthcare would come out of your pocket before the insurance kicked in.
And why are deductibles so high? Why aren't they lower?
Well, I think our problem is we have a one-size-fits-all approach. A lot of employers don't make allowances for the fact that some of their employees have a lower income, and so it's just very unaffordable for them to have a high deductible. There is a program for people who have coverage on their own through the Affordable Care Act that tries to and does in fact give additional help for people who are at lower incomes. So if you're at between under 4 times the poverty level, which is roughly about $51,000 for a median family, then you're going to get extra help with your deductibles, and it'll lower them. It doesn't always completely eliminate them, but it does bring it more within reach for each family's budget.
David, at Third Way, that's a think tank where you work and look for solutions to the problems in our healthcare system. And there are a number of things that states are doing to try and ease the burden of medical debt. There's financial assistance, changing billing practices, or preventing interest from being added to the debt. So from your perch, what are the most effective measures states should be taking to ease the pressures of medical debt?
Yeah, great question. One of the best provisions I've seen at the state level is a requirement for hospitals. Now, you got to back up for a minute and know that hospitals receive a lot of state and federal money, so in various ways. So in exchange, what states have done is ask the hospitals to, provide a certain level of free care for people who are under that poverty level, often up to 4 times the poverty level. And this just is a standard for providing charity care that comes with all this. For a lot of nonprofit hospitals, they get state and income and federal income and property tax exemptions. So that's a good system. Now, the thing about it is that Michigan hasn't done this yet. So about half the states have. So if you're out there thinking about what to do on this issue, that would be a good first thing to contact your state legislator and say, can we get the hospitals to provide a certain minimum level of charity care?
I'm wondering if you think the federal government should be stepping in here and simply erasing a medical debt when people have it. Is there any purpose to medical debt?
No, not at all. I mean, it's just a tragedy in our healthcare system. It's well, at a larger scale, it's warning signs that something's wrong. As the previous discussion really aptly pointed out, it shouldn't be happening because people do need to get the care that they sometimes can't afford, and so it's just something we need to, should realize that we need to do better at. And so, yes, the federal government does have a big role in relieving this debt. What I would like to do would see is have the debt erased for everyone who gets coverage, and make sure that coverage is adequate. So that would make sure that the problem is prevented in the future by having people have adequate coverage that doesn't have those high deductibles for people who can't afford them, and then wipes out that debt that has accumulated because of other problems. One of the things that we are still dealing with is the fact that a few years ago, we eliminated surprise billing. You may remember that, where a hospital or a doctor could just
David, I hate to tell you we are running out of time, and I wanted to just ask you one more question in our last 30 seconds. Is there any rich country with a better healthcare system, one that's closer to the golden standard for providing care?
I think most other countries have gotten it better than we have, and to illustrate the problem, a lot of countries have found have been at it longer. We're still figuring it out. We're going to do it in an American way, but I still think we can do a lot better than we have been doing today.
David Kendall is a senior fellow for health and fiscal policy at Third Way, a think tank that champions modern center-left ideas. David, thanks so much for joining us on the Metro.
Thank you.
And that is the Metro for Tuesday, December 17th. The show is produced by Sam Corey, Carey Jr. II, Jack Philbrandt. Our engineer is Nate Bender, and our senior producer is David Lyons.
This is WDET-FM, Detroit Public Radio, your connection to news, music, and conversation. Thanks for listening.
See you tomorrow.